Next presentation, the last one for the session, transoral incisionless fundoplication, or TIF, as a treatment for gastroesophageal reflux disease in children, by Joseph STATHOS.
Good morning. Thank you for letting me present today. I'm a first-year medical student, and this is my first international speech, so please have mercy. So, our methods analyze the use of a transoral incisionless fundoplication device, also known as TIF, in adults. It has been described as an effective, minimally invasive method in the treatment of gastroesophageal reflux disease. Our study included 8 patients, 8 to 18 years of age, who all weighed at least 30 kilos, and included 2 females and 6 males. All had endoscopic evidence of GERD, and histological findings consistent with inflammation associated with GERD. All of the patients underwent a pre-TIF and post-TIF endoscopy with a Bravo pH probe. The percentage of time with a pH of less than 4 in the esophageal lumen, as well as the Demeester scores, were compared in the pre-pH probe and the post-pH probes done 6 weeks after the TIF. All patients were initially admitted to the Rocky Mountain Hospital of Children and observed. The TIF procedure is performed by 2 physicians. One physician is operating the TIF device, while the other is providing video using an endoscope. The fundus of the stomach is manipulated using the TIF device, as you can see here, and H fasteners are fired through the tissue to create a plication, as seen in this slide. Fasteners are used in a methodical fashion to build a plication in the fundus, as you can see in these following images, in a circular form. In our findings and conclusions, the intraluminal time for a pH of less than 4 on average decreased by 72%. The total Demeester score done on pre and post pH probes decreased on average by 69.9%. All patients had a histological improvement on biopsies done before and after the TIF procedure. There were no complications that occurred during the procedure. One of the patients has subsequently undergone a laparoscopic fundoplication due to a recurrence of symptoms, and the TIF technique appears to be safe and effective in the pediatric population. There's a clear improvement in both the esophageal pH, the Demeester score, and histology and pre and post pH probe studies. Thank you very much for your time.
We have a question.
Yes, congratulations for your presentation. Is there a limitation with the body size of the patient? I see that your youngest child was 8 years old.
I'm sorry?
I'm sorry.
Is there a limitation in the patient's age or size?
Body weight? Yeah, size is a very important factor, and that's a great question. But I would probably like to refer to one of the other authors for that question, if I may.
Were there any other selection criteria for this patient population, or how did you choose this over fundoplication?
So the patients were chosen mostly on the fact that they were successful on proton pump inhibitor use. They had another reason to not want laparoscopic fundoplication, such as fear of lactate vomit or burp afterwards. Most of the patients actually were teenagers, and interestingly enough, all of them saw this as a separate approach as opposed to laparoscopic fundoplication. I thought it possibly easier than to do more permanent laparoscopic versions.
I have a short question also. Thanks for your presentation. I mean, we all are aware if we have new devices, that takes time to become familiar with these things, and it looks a little tricky to have 3 things in the hand and there are 2 persons dealing with that. So is there any maneuver, let's say like this, to rescue if you can't, if it is bended already and you can't use it properly within the body of the patient? Is there any idea? Did that happen?
Yeah, thank goodness we didn't have any malfunctions of the equipment. I could imagine it being a horrific experience because you essentially have a very large device sticking out into the mouth, and then if this was articulated inside the stomach, there would be virtually no way to get it back out.
Thank you.
We have one more question.
The time passes between the pre and post-op biopsy studies.
I'm sorry?
How many days, months after the surgery?
Oh, our
did
earliest
you
patient.
perform the biopsies?
Right. Our earliest patient was done in 2009. So after about 6 months after the surgery, we began to do biopsies again, and then have been continuing to do those.
Because the changes in
over
the
the last
esophagus are not so quickly.
Right.
They are so slowly after the surgery, even after the Nissen fundoplication.
We performed biopsies as soon as we thought it was the patient would be able to handle them.
Thank you.
That concludes this session. We have a short break, a few minutes before the next session starts.